Lisa, you're on mute again.
I am ready, as far as I can tell.
Okay, so wonderful. So let me introduce you all to this webinar and panel discussion. A very good evening and a warm welcome to you all. Mohan Foundation, in association with NATO and Commonwealth Tribute to Life project, is absolutely delighted to welcome you all to this webinar and subsequent panel discussion on non-directed altruistic living donation. So in India, while there have been remote cases of altruistic kidney donations by living donors, it is generally met with a lot of skepticism by the Indian systems. At Mohan Foundation, we do receive requests from individuals who seem to be genuinely interested in altruistic kidney donation, but we turn them away as the present processes have no provision to verify the intent or to enable such requests. So the objective of this webinar is to explore how the healthcare systems in UK and the other countries enable such requests, and what are the processes around counseling, evaluation, what are the safeguards in place. The idea is to initiate a discussion on this topic and hopefully bring about policy changes in India so as to enable non-directed altruistic living donations. I am Jaya Jairam, the project director at Mohan Foundation. I'm based out of Mumbai. And it gives me great pleasure to introduce you to today's speaker, Lisa Burnapp from NHSBT, UK. I'm going to briefly read out Lisa's profile. Lisa has a background in nephrology and transplantation and an MA in medical law and ethics. She was appointed as consultant nurse in living donor kidney transplantation at Guy's and St. Thomas's NHS Foundation Trust in 2002. Where she retained a clinical attachment with a special interest in non-directed altruistic donation until March 2022. She is the Associate Medical Director for Living Donation and Transplantation at NHS Blood and Transplant and has facilitated development and implementation of UK strategies for living donor transplantation, including the UK Living Kidney Sharing Scheme since 2010. She's the current president of the British Transplant Society, that is BTS, and was a founding member of the BTS Living Donor Forum and co-edited best practices guidelines for the society over a number of years. She has been a member of the Human Tissue Authority Transplant Advisory Group since its inception in 2005 and is on the Living Organ Donation Working Group within the ethical, legal, and psychological aspects of transplantation section of the European Society for Organ Transplantation. I welcome you, Lisa. It's such an honor to have you here. Over to you.
Thank you, Jaya, so much for your introduction and for the invitation to join you this morning. I'm absolutely delighted to be here. I hope my technology stands up to scrutiny, and I'm going to try and share my screen and a slide presentation with you just now.
Before you begin, I'd like to request the audience to type your queries in the chat box. Thank you. Thank you. Over to you, Lisa.
Inflation increase 2.5%.
Jaya, can you just confirm that you can see my slide?
Yeah.
Yes, we can see, but it's not full screen.
Excellent.
Can you please make it full screen?
It
go
is
to
full
slideshow
screen.
more.
I have put it on slideshow. I think there may be a delay, which could present a little bit of an issue as I go through, but I'll try and keep the momentum going. Is it on full slideshow now?
No, not yet.
Not yet.
I think this is going to be the challenge. I'm just wondering what the best thing to do here is. Can you see, what can you see at the moment? All my slides?
Yes.
Yes.
Okay.
Just go to normal view.
Yes, I'm just going to, I think I might have to do that. So I'm just going to stop sharing for the moment. I think there's a big delay. Just bear with me a moment. I'll try and think of something else.
No worries.
Can yeah, you could introduce perhaps a few others panel while we're waiting.
Sure.
I'll go on to normal view. Can you see that as, let me just try and put in this into normal view, but please do go ahead and continue to introduce, and I'll see if I can sort out the technology.
Sure. So we have Dr. Sunil Shroff, who is the founder and managing trustee of Mohan Foundation here with us. Hi, Dr. Shroff.
Yes, this.
Yeah.
Yeah.
We have Dr. Anil Kumar, who is the Additional Deputy General, DGHS, Ministry of Health and Family Welfare here.
Yeah. Good evening. Good evening, everyone.
We have Dr. Dale Gardner, who's the Associate Medical Director of Deceased Organ Donation at NHSBT, and he's also the head of Commonwealth Tribute to Life.
Good evening and good afternoon, everyone.
We also have Dr. Satya Sharma, who also heads the Commonwealth Tribute to Life project based out of the UK.
Good afternoon.
We have Bob Wiggins, who is an altruistic kidney donor based out of the UK, and he's been introduced to us by Lisa. Hi, Bob.
Hi, good evening.
We also have Reverend Father Davis Chiramel, who has joined us. He is based out of India, based out of Kerala, and he is well known as the kidney priest. He had donated one of his kidneys to someone else in Kerala. So it's going to be an interesting discussion today. I'm looking forward to it. Lisa, are you ready?
Yes, well, I think I'm as ready as I can be, Jazz. So can you see a set of slides in front of you on, yes. What I will do is, I'm so sorry, some of these are animated and we'll miss a little bit of the nuance, but I don't think it'll matter too much. Just once again, thank you so much for inviting me to join you. Apologies for the technical difficulties, but it's a real pleasure to be here and to talk about something. I mean, living donation is close to my heart, but non-directed altruistic donation, or non-directed donation, as we tend to call it in the UK, is especially close to my heart. And I just want to talk today, I suppose, and for us to think about this in the framework of something that this is, many of you will recognise Peter Medawar, who was the inaugural president of the British Transplantation Society, and we have just celebrated the 50th anniversary of the society. And Peter talked a lot about the art of the possible. And in the 1960s in the UK, the question was being asked whether kidney transplantation in itself was ethical for patients with kidney failure. And his response to that was, well, that's very simple because people would rather live than die. And actually, although this was now 70 years ago, I think this is extremely pertinent to our current debate as we try and push the boundaries in transplantation, and particularly in terms of our topic today, in terms of living donation. So just to give you an overview of living donation in the UK. So living donation in the UK is 98% kidney and 2% liver. And that's, of course, a very different picture from what you have in your own country. And we're very much hoping to develop the liver side of our living donation programme in the coming years. So my talk today is going to really be based around the UK experience around living kidney donation in the non-directed context, because we do have a very, very small number of non-directed altruistic living liver donors, but in comparison with the number of living donor kidney donors in that way, far fewer. So I'm going to talk about basically talk more about living donor kidney transplantation and non-directed donation. So I suppose our confidence in looking outside the traditional historical relationships of family blood relatives started with Paul Terasaki's data that was emerging from America in the mid-1990s, which showed us that, in fact, there were equally good outcomes, clinical outcomes from patients who were unrelated by blood as those related by blood. And this, together with over the next decade, our experience within the UK of patient survival after living donor transplantation and transplant survival after living donor transplantation began to persuade us that we could be really moving in different directions. And we already had, by this time, a programme that was pretty much embedded in our family tradition in terms of family members, whether they were related by blood or emotionally related by marriage or partnership. And even, in fact, at this time, we were accepting friends as well, close friends of potential recipients. So we were beginning to move in that direction in the confidence that the outcomes were equally good. So we were persuaded, I think, by that time that living donation was a good thing to do. And I'm going to come back to this at the end, because this is a really, really important thing. Because when we're talking about non-directed altruistic donation, we have to believe it's a good thing to do. So at this time, in the middle of the 2000s, we were looking at excellent outcomes. We were looking at creating opportunities and choice, not only for people who had a living donor, but for people who didn't have a living donor and were waiting on the list. And therefore, their opportunity to receive a deceased donor transplantation by expanding the donor pool was enhanced. And economically, it made absolute sense, because we could offer more patients the opportunity to escape dialysis and have a long transplanted life. Let's move down my slide deck a little bit now. So over that first decade of this millennium, we saw a threefold increase, and you can see there shown in the grey bars, in living donor transplantation at a time when, as you can see in the light blue there, that was equivalent to our what we call our donors after brain death now, and the dark blue bars where we were beginning to see an increase in our deceased, in our DCD donation, our donation after circulatory death. But really there was a really meteoric change in the way we approach living donation in the UK. And at that time, we were beginning to reach a little bit of a plateau, and we were producing strategies not only to support deceased donation there on the left of this slide, but also alongside living donor kidney transplantation. And then subsequently in our current strategy, we have living and deceased donation in the same strategy that will take us over the next 10 years. And for me, that's really exciting, because that has been driven by the success of living donation and the fact that people have taken this into their hearts and minds. So in the first 10 years of our living donor kidney transplantation strategy, we wanted to focus on giving people more options for living donor kidney transplantation, creating more living donor opportunities, and maximising the use of our kidney sharing scheme, which is our kidney exchange programme, amongst other things, of course, but these are key to the subject we're talking about today. So I just want to focus for a little moment on our kidney sharing scheme, because this is really the platform for our non-directed altruistic donors now in the UK, and has become the game-changing part of this scheme. So our scheme, as most people will be aware, was started because we had a proportion of patients, of donors willing to donate to their recipient or their loved one, but were unable to do so because around 30% of them were incompatible by blood group or HLA type. Really importantly, and again, an absolutely fundamental part of our programme, is that there was a change in the law. So in the middle of the 2000s, we saw the Human Tissue Authority come in under the Human Tissue Acts, and they are responsible really for the oversight and the legal framework for living donor kidney transplantation. And really importantly at this time, they made explicit in those Human Tissue Acts across the UK that paired exchange was feasible and legal, as was non-directed altruistic donation from a stranger. And that was absolutely key, that change, because if you have a law that does not permit those relationships, you are very restricted clinically with how you can develop the service. So that was a game-changing moment. So in terms of how our scheme operates, we started in small beginnings in 2007, having developed the way in which we wanted to work, and we depend on the software developed with in association with the University of Glasgow to run our matching runs on a quarterly basis. So in 2007, we ran our first matching run in April with 9 pairs, and we identified one two-way exchange between 2 incompatible couples. As we proceeded through 2007, we could see the benefit of the scheme, and so in 2008 we introduced the opportunity for 3 couples to exchange in the same way. And then at this time, our non-directed altruistic donors were coming forward, not in enormous numbers, but they were all donating directly to our our UK transplant list offered in the same way as our deceased donor kidneys would be. So they were prioritised on a UK-wide basis and just directly to the list. In 2012, we introduced the option for those donors to choose to go into the kidney sharing scheme to initiate what we call a short, simultaneous chain of transplants with a donor-recipient pair in the middle. And the way this worked was that the non-directed altruistic donor would donate to a recipient in the pool, and in turn, their paired donor would donate to somebody on the waiting list. So the opportunities that were opened up were doubled by their donation. So one donation creating 2 transplant opportunities. Such was the success of this that we moved into, in 2015, into adding another pair in the middle. And so that created 3 transplant opportunities out of that single trigger donation. And of course, the benefit here is that this non-directed donor has no recipient attached to them. So they were free, if you like, to be matched to any recipient in the scheme. And this was all done with the blessing of the clinical community. So we only made changes when all 23 transplant centres across the UK and their non-transplant centres were on board with the idea. And that was critically important because that's a hearts and minds thing. In 2018, we made a really big change. We were seeing the benefit of our non-directed altruistic donors in our scheme, but what was happening is that their assessment was taking, although they were very committed to donating into the scheme and creating these transplant opportunities, by the time their assessment had completed, they were ready really to just get on and donate, and were reluctant to wait to go into a quarterly matching run. So in 2018, we changed it to a default position that all non-directed altruistic donors would enter into the kidney exchange programme, only if there was not a high priority recipient on the waiting list. If there was a high priority recipient on the waiting list, their kidney would go directly to that individual because that was their golden ticket transplant. And in this way, we thought that we could make more impact on the scheme. So you can see over time here on this chart in the pale blue that there's been an increasing proportion of our non-directed altruistic donors who've now gone into that scheme over the years. And let me just show you something about the impact. So you can see here, in 2014, while we had the kind of opt-in system, if you like, for our non-directed donors into the sharing scheme, about a quarter of them were actually entering into the scheme. And even that, with that quarter, we created an additional 23 transplant opportunities over and above the 110 donors that we had at the outset. If you move on to 2019, where we had a similar number of donors, slightly fewer, but we created 186 transplant opportunities by the addition of around 50% of them going in the scheme. And even during the pandemic years, we were able to make a difference. 62 donors, obviously the number was lower because of the pandemic, creating almost 120 transplant opportunities. So really the message here is that this was a real game-changing moment. So out of about almost 1,000 now non-directed altruistic donors over the years, since May 2007, just around half of them, slightly more, have gone into the scheme to create those chains of transplants. And the impact has been extraordinary. So our requirement for antibody incompatible transplantation, both for our HLA and our ABO incompatible transplants, has become negligible. It's really restricted now to those patients who cannot be matched with anybody in the scheme, but is really vastly reduced. And of course, that's better outcomes for patients. We also have managed to address health inequalities through this scheme, because whilst our 97% of our non-directed donors come from a white background, around 20% of the recipients, either in the shared scheme or through direct donation from non-directed donors, are now benefiting from a transplant in the UK. And this is really, really important, because our patients from Black, Asian and mixed race and minority ethnic backgrounds are disadvantaged and on our list. And so the slightly overrepresentation of living donor transplantation, we believe attributed partly to this scheme and partly to an increase in donors from those populations, is actually very helpful indeed for those patients. So overall, you can see that the characteristics of our living donor transplant programme over the last 15 years have considerably changed from the traditional relationships between blood relatives or emotionally related relatives into these areas where we're now much more driven, and around a quarter of our programme is made up from our non-directed donors and the transplants achieved through the kidney sharing scheme. You can see the impact of COVID there, and now the recovery from COVID, and I'm glad to say we're back to about 80% of activity. But really strikingly, we're still seeing 20 to 25 non-directed altruistic donors going into every kidney exchange quarterly run, and that's a phenomenal experience. So internationally, the implication of this is that we've been able to develop a way of sharing living donor kidneys and triggering living donor transplants in a way that actually makes us one of the largest programs in the world. So our new strategy then gives us an opportunity for living donation to be embedded across society, and that is not only for recipients, but it's for all people in society to consider that whether or not this is an option for them. And of course, that relates very heavily to the non-directed altruistic donor agenda. And our aim is partly evolution, partly revolution, as Dale would always say, about maximising living donation, both kidney and liver, but in particular, the utilisation of our non-directed altruistic donor pool. And this is particularly important post-pandemic because we have seen a rise in waiting lists, an increase in patients waiting, longer waits, and people dying on the list. And this is something that obviously everybody is concerned about addressing. Now, this next slide really, behind the animation would have been, what do we fear as a group of professionals? And partly we fear what we don't understand. Why would people just spontaneously come forward and donate in this way? Is this something that we can understand when they're not related or there's no proximity to the recipient? And of course, fundamental to the way we run our clinical practice is we must first do no harm. So the thought that we might do physical or psychological harm, I think physical harm, we're probably content that living donation, we make it as safe as we possibly can. But this idea of psychological harm with a lack of proximity to the donor is something that really, I think, does trouble us. And it is something that our medical colleagues have had to move with. And I think I'm going to leave Bob to explain to you how that plays out in terms of his own experience. So finally, I think that removing the barriers to non-directed donation, or indeed living donation actually, but in this particular context, are about the 3 Ps. It's about people knowing they can do it, that it is something that is possible for them to achieve. And I don't think we have that level of awareness yet universally. It's about policymakers having proportionate legal and ethical frameworks to allow relationships and clinical practice to develop in the way that it spontaneously can evolve, given enthusiasm from the population, patients and their families. And it's about professionals believing it's a good thing to do and that they're willing to participate in it. I've identified these papers as really depicting the UK experience, and particularly the first paper looks at how the involvement of the Give a Kidney charity, which Bob will speak more about, has enabled us to drive this momentum forward and raise awareness within the UK. And the Bound study, there are several papers there looking at attitudes of professionals, the understanding it from a donor perspective, and how it sits in context of all of that. So on a final note, the mantra of Give a Kidney is no waiting for want of a kidney. And I would say to you that if you open your doors to the world, wonderful people walk through it. And these people are the people who have donated and made that difference in our UK programme. It is about hearts and minds. It's believing it's a good thing to do, and it's making it happen and having the enthusiasm to do that. I'm supported in my work by an enormous number of people, and this is just some of them who need to be acknowledged in the context of this programme. And finally, thank you. I look forward to our future discussion, and that's how you can contact me. And now, over to Bob.
Hello, everybody. Thank you for inviting me. It's quite an honor, honestly, to be involved in this, and what a journey this has been in the UK, and I imagine in India as well. I donated in 2013. The process before that is a little bit of a blur to me. At some point, I became aware that we have a spare kidney if we're healthy. And it could be donated to a person that doesn't have any healthy kidneys. And I guess at some point, I just sort of Googled the idea, thinking, well, I could probably give somebody my spare kidney. I don't see a problem with that. It's very sort of matter of fact in my mind. And over time, I learned more and informed myself before making contact with one of the transplant centers. Which took it from there. And as I say, in 2013, I donated to a stranger. It never occurred to me that would be, I guess I knew most people probably wouldn't do it, but it didn't seem that unusual to me. And I was surprised to find out that it was only several years earlier that it was actually possible to do so. I guess the motivations, I sort of, with my work with Give a Kidney, I've had the opportunity to speak with many donors and learn more about each person's motivation. As individuals, we don't have a lot in common. We come from all walks of life. We have different interests, but there are certain things that we do have in common. And most people, if they're considering this, have heard a story on the radio. I don't remember having done so, but or on the radio or on television or on the newspaper. Or they've had an experience with a family member or a close friend that's in need of a kidney, or who may have died as a result of kidney disease. So there's sort of that act of coming forward, and there's a realization that we say, I could do that. I could do that. And what's different between the people that say, I can do that, versus the one saying, oh, I don't know about that. That sounds a little bit, especially to a stranger. I might to a family member, but I'm not so sure about a stranger. And I think what it comes down to, and this is just anecdotal, I don't do any research, and I'm not an ethicist, but one, we have we see the risk is low. Now that comes from informed consent, and through the whole process, the NHS is very good at informing us of what's involved, what it means, what we know, what we maybe don't know, where the risks lie, the likelihood of those risks, so that we can make an informed decision. And for those of us that have donated altruistically, it's been a case of, well, that seems like a reasonable risk. It's a low risk. It's not too different from continually driving on the UK roads over a period of time, sort of in mortality terms. The more common risks are usually easily resolved. If it's an infection or etc., then in most cases these are easily resolved. If it's more serious, then they're also the occurrences are very low. So we have I think we're able to be very objective about risk, and talking with other donors, we can talk in terms of percentages, relative risk, what it means against other things that we do in life. It's not too different from having a hip replacement operation. So would we not have a hip replacement operation because of the risks of it? Some people might not, but that comes on to anxiety. What level of anxiety do we have about going into a hospital, being put under, and actually having one of our organs removed? Many people, the anxiety would be too high to do that. Or maybe just the anxiety in their family would be too high for them to do that. But for us, there wasn't a high level of anxiety. So low risk, low anxiety. The other thing we have in common is opportunity. and this does skew the population, I think, a little bit. We usually have a life that allows us the flexibility to take the time off to go through the working up process. We have the flexibility to take time off for the recovery, and probably a financial situation that allows us to do so. So there's a sector of society where that's more easily done than perhaps others. Family circumstances also feeds into opportunity as to whether one is able to donate. And the fourth factor is empathy. And the common factor is that most of the people, if not all of the people that have donated altruistically, have a heightened sense of empathy for strangers that are in difficult circumstances. We don't need to know them personally. We're bothered by people who suffer. We're unlikely to walk by somebody on the street that's having a problem. And it's that drives us forward, that we have something somebody needs that we don't need. And it's going to make a huge difference in their life. For some people, it may actually save their life, but as a minimum, it transforms lives, and not just of the recipient, but of their families as well. And that's what drives us. So when that empathy and opportunity is greater than the fear of the anxiety and the appreciation of risk, then it drives us forward to donate. And in the research that we've carried out, and take this with a pinch of salt, but it's the research that's been done, that 10 to 12% of the population would consider donating a kidney to a stranger. I think when it comes down to it, probably that percentage is a lot less, but nevertheless, on the face of it, that's what comes forward, which is we're not oddballs. We're not on the fringe of society, and we're not loonies. We just have this heightened sense of empathy and the opportunity to help somebody. And that's what drives us. And we're up to nearly 1,000 people, if I'm not mistaken, having donated altruistically since the law has changed. And there's the post-donation experience. Almost universally, people it's been a valuable experience to us. It has enriched our lives, regardless of whether we know the recipient or whether we don't know the recipient or whether we haven't heard the recipient. Most people, almost everyone I've spoken to, I haven't talked to anybody that said otherwise, but there may be some, but it's enriched their lives in doing so. So I think that not only does having given been an act, but most of us want to engage further and help others to raise awareness. And hence, Give a Kidney was formed in 2011 by a group of people who had donated prior to that time to raise awareness. We're not telling people they should donate, but just, do you know you can, and should, you might want to consider it. And this is where you go for information, and we support people in doing that. The biggest, I think, thing we've done is work with NHSBT and help raise the profile of non-directed altruistic donation, which has made I think Lisa would say, it's made a real difference by working together. We couldn't have done it without NHSBT. And I think that things have moved faster than they otherwise would have without Give a Kidney there. And we've built the foundations. We're expanding on those foundations, and that collaboration is really important, I think, between a independent charity and the NHS in the UK, working together to do this. So I guess those are the messages I wanted to express. Personal experience, having dealt with lots of donors in the UK, what we do have in common, what we don't have in common, the importance of having a charity there that offers resources and support for people that are considering it, but that works hand in hand with the National Health Service as well. So I think I'll probably stop there. I could go on for days about this, but those are the key messages I think I'd like to pass on. But thank you very much for your time.
Thank you, Bob. Very, very insightful. I keep wondering, how do people like you even come up with, how do you think about this? So it was really insightful. Thank you for sharing that. Thank you, Lisa. I'm going to quickly move over to inviting Reverend Father Davis Chiremel. Welcome. I'm going to introduce you to him. So he is popularly known as the kidney priest in India. He is an Indian Catholic priest and the founder of Accident Care and Transport Service and the Kidney Federation of India. He donated a kidney to a man of Hindu faith and inspired many other priests to donate their spare kidneys. Welcome, Father Chiremel, and could you please share with us as to what motivated you to consider donating one of your kidneys? You're muted, Father Chiremel. Can you please unmute yourself?
Yes. Thank you. Thank you very much, everybody. Dr. Anil Kumar and everybody before me. So it is a special occasion for me to talk to you. You ask me, I can answer you. That is a better thing. But I shall say something about my experience now. It happened in 2009, September 30th. I was not behind to give a kidney, No. It happened that size, but it is a blessed moment God has given to me, because I preach only. I'm a priest. Preach and preach. You give. And now I got an answer. I will tell them, not only preaching, I am doing that. But
you walk the talk.
You see, and also this thing, this altruistic donation. I'm not seeing this as a donation, but it's a blessing for me. I can be present with my energy, with my the happiness to speak to everybody. See, in Kerala, I conducted 2, 3, 4 campaigns all over the district and conducted 10 lakhs of organ donation forms and hand out to Noto. And I was invited to Delhi also. And I told them, you see, this is our best social activity, not to donate in living donation or altruistic donation. I'm telling them disease donation, but I, being an altruistic donation donor, it is for me, it is very easy to preach the thing. And also, I have only seen a living or altruistic donation. I have not seen a donor, a deceased donor, because we cannot see a deceased donor. A deceased donor is no more. So I could make a difference. See, I was watching the World Cup now. So Messi made a difference, and he is happy. I don't know how to play football, but I made a difference, and I am more happy, like Messi. See, everybody wants happiness. The happiness is when we are a person to give something to somebody. So we get the meaning of life. I am every time I'm preaching and I'm telling people, you donate, not only kidney, you can donate anything, then you get the happiness. If you are able to donate a kidney, see, people will asking, why Father, you have got that motivational energy. See, I am not telling you anything out of me. I am telling what I am feeling in my mind. Because my recipient, Gobinath, when I see that Gobinath and a smile on his face, that is enough for me. And often he will call me, Father, how are you? Yes, very fine. How are you? Yeah, very fine, Father. Yes, that word, if somebody says, I'm very fine, that is different. When Gobi calling me, how are you, Father? Yes, I am fine, Gobi. How are you? I'm happy. What about your children? So they are doing well. And I'm happy, Father. See, this altruist, to become an altruistic donor, it's a blessing. It's a totally blessing. Not only that, people are making that religion, this religion, and this group and that group, and you are a lady and I am a gentleman. There is no difference. Kidney has no religion at all. Kidney has no religion. Kidney will go to any person. See, my hope and my praise, if this war is going on now between countries, the only solution to cease war is share the kidneys between countries. My one kidney from Indian kidney is in Pakistan. And we cannot make war because my kidney is there. Don't do war. See, the harmony, international harmony can be obtained by exchange of kidneys. Now, as Dr. Lisa told here, I have started a hope registry. I call it cross donation. But internationally, it is called paid donation. But I do it in Kerala, cross donation. Aster hospitals are doing that. And it is going on well. Hundreds of people are benefiting out of it, cross donation. And also after me, I think in India, Kerala is the state in the highest number of altruistic donors, because no other states, they are not giving permission. No altruistic donors. They are doing receiving money and giving kidney. No, we will not allow you. But in Kerala, after me, 400 people, more than 400 people came to my path, and it is allowed. I think in India, Dr. Anil Kumar will be able to say more about that. Only in Kerala, we are blessed with the permission granted by the government to become an altruistic donor. I had been in UK, Dr. Lisa, and NHS with them. I had a campaign there from Scotland to London. Also, I had conducted a organ donation campaign, and I also people made them to sign the form also, and also this cancer, delayed cancer, or an organization from Germany. They want to people to become these bone marrow donors. I also given them. I'm waiting them. If I get a call, I can go to Germany and donate my bone marrow also. See, the happiness is not receiving. Happiness is to giving. So I'm very thankful to my Jesus, because God gave me a blessing that, and I can tell people now, this is the happiness. So to become an altruistic donor, it is not easy, and also it is not possible to everybody, because there came so many priests came, nuns came. Father, I want to know, you are not eligible. You have no such health. You are not able to. God, doctors will not give you permission. So I am blessed with health, and I also blessed with happiness, and I'm so happy to talk to you.
Thank you, Dr. Chiramal. Thank you, Father Chiramal. It's such a pleasure to hear you speak. Due to shortage of time, we'll have to move on. But
thank you.
Absolute honor to hear you and Bob speak about your experiences. Thank you so much. We will, due to shortage of time, we'll have to move on to the next session. But we really pray and hope that you can continue to inspire many such people with such a positivity and a huge smile on your face, Father.
One more thing. Excuse me. Next week, I'm going to Kuwait. The country, the health department invited me to make a campaign in the country Kuwait. That is for disease donation. I'm going for that. And also Oman, all the JCC countries, they are inviting me. That is my pleasure. I'm going. I beseech your prayers.
We wish you all the very best. May you inspire many more.
Thank you.
Thank you so much, Father Chiramal. Thank you. All right, so now we move on to the next session, that is a panel discussion. And without any further delay, let me quickly introduce you to today's panelists. Dr. Sunil Shroff, I already introduced you all at the beginning, founder and managing trustee of Mohan Foundation. Dr. Anil Kumar, additional deputy general, DGHS, Ministry of Health and Family Welfare. Dr. Archana Kumari, is she in? Pallavi, has she joined in?
See her. Yeah, Dr. Archana Kumari is there.
Okay. We have Dr. Archana Kumari, Consultant Coordination of NATO at NATO, Delhi. We have Dr. Sanjay Nagral, who is a publisher at Indian Journal of Medical Ethics and the co-chair of Declaration of Istanbul Custodian Group, that is DICG. We have Dr. Dale Gardner, who is the Associate Medical Director for Deceased Organ Donation at NHSBT. He also heads the Commonwealth Tribute to Life program. We also have Kamal Shah, a good friend of mine, and who's also co-founder of Nephroplus, which is a chain of dialysis centers, and he has been on 25 years on dialysis himself. I extend a hearty welcome to each and every one of you. Thank you for your valuable time. Apologies for the delay in beginning the panel discussion. Let me begin by asking my first question to Dr. Sunil Shroff. Dr. Shroff, as a young kidney transplant surgeon, you returned to India from the UK at a time in the 90s when Tamil Nadu was infamously known as the hub of kidney commerce. I remember having read somewhere that the place Villivakkam was actually called as Kidney Vakkam over there. So since then, we've come a long way. I'd like to invite you to share your thoughts on this. And also, do you think India is ready for non-directed altruistic living donations? I would also request you to share your experience of somebody reaching out to you. Could you please share?
Thank you so much, Jaya. Very keen to start this non-directed, altruistic donation in India. When I came in '95, at that time, there was so much of organ commerce happening. The law had just been passed. The Indian law, I must say, is one of the toughest laws in the world. But despite that, people have overcome the requirements, and organ commerce have happened. But I think in the last 10 years, organ commerce has come down. It's not that it's not completely wiped out. It's still happening in pockets, small pockets. But I think, as a foundation, when we established, now we are 25 years old foundation, we keep getting these requests for altruistic, non-directed donation. They're genuine requests. Currently, I have a gynecologist from Bangalore who wants to donate her kidney. And she doesn't want, obviously, any financial, there's no financial incentive there. So like that, we do get these requests from, and they are very strong proponents. In our own group of our foundation, Dr. Ravi Wankade in Nagpur donated his kidney to a Bora Muslim. And this was about 10 years back. So this, I think, is definitely a way forward. What we need to create is a proper template. What kind of evaluation we do, especially when there is a financial disparity between a recipient and a donor. And when the numbers increase, there should not be coercion happening, because we are always haunted by organ commerce in our country. There is a lack of trust. The trust factor is missing. So in my experience, I think we're now ready for this move forward. We would need guidance. We would need help from people like Lisa, her experience on how to create the right template, so that the fear is, of course, as I said, the financials kind of creeping into this wonderful program, if when it happens. So definitely we are ready for it, I feel, because now our disease donation numbers also are moving up. And there's a lot of opportunity of mixing and matching these donations and increasing the number of actual kidneys, as Lita showed in her presentation. And that will really help, especially with the ABO incompatible transplants going on in the country, which are so hugely expensive. I think doing this, we could overcome that, definitely. And I'm very happy that Dr. Anishma and Archana are here. Perhaps, we could sit down together with the experience of Father Chiramal, Lisa, and others, and create that right template in India. This is one of the dreams which we have in one foundation to help the program to increase the donor. Thank you. Thank you, Jaya.
Thank you, Dr. Shroff. My next question is for Dr. Sanjay Nagral. Welcome, Dr. Nagral. When we talk of living donors, there's always this ethical question of individual autonomy versus do no harm. This is something that Lisa did mention in her presentation. However, it's amazing to see when Bob shared that somehow, like, for example, I am a kidney recipient. My mother donated one of her kidneys to me. I know that every time she sees me, even when Father Chiramal was sharing that when Gopinath calls him, he derives tremendous satisfaction or joy from just knowing that they have been instrumental in giving a second chance to somebody else. However, in case of non-directed altruistic living donors, it would somehow seem that they carry all the risk, and it's totally skewed. What's the benefit for them? So how does this work? Could you please share?
Yeah, thank you. So can you hear me?
Yes, Dr. Nag.
Okay, all right, thanks. So first of all, thank you. And let me begin by saying that it is indeed quite humbling to see the experiences of Bob and the father. And really, one of the questions that always will come up is what is the motivation? Because after all, it is an operation. After all, there is a finite but small risk to the donor. So before I try and answer your question, let me also add a little bit to what Dr. Shroff said, which is that in India, we have a history. And we are just taking steps towards trying to wipe out that history, trying to move towards a more ethical form of donation, a more transparent form of donation. And therefore, the introduction of any such idea, howsoever appealing it seems, needs to be done very carefully because of the nature of the healthcare system, which is quite different from the NHS. Now, to come to your question about the individual, so the question of the risk versus the benefit and the autonomy, I think clearly to me, every case will have to be dealt with on its own merits, because finally, even for altruistic non-directed donations in the Western world, where it's probably now a fairly regular feature, and maybe Dale or Lisa can tell us more, but there's clearly a process where there is an attempt to look at what is the I think there is a psychosocial analysis. I think there is a process of looking at what exactly is the motivation of the individual, etc. So I think every case is different. There will be individuals who will be doing it out of a sense of social good, solidarity. And I have a feeling that it's also about their spiritual understanding, their religious understanding. And I think there's been some work on this as to who donates and what are their motivation when talking of the altruistic donations. But clearly, when it is India, we will have to take it on a case-to-case basis, look at the motivation, because we don't want to take steps which will have collateral damage on the other good work that is being done. I don't know whether I've answered your question, but I just sort of laid out the Indian terrain and its challenges.
Thank you, Dr. Nagral. Clearly, there's no single glove that fits that fits everything. So will have to be looked at on a case-to-case basis. However, having a template that sort of analyzes, sees out the genuine ones will therefore be crucial. That's what I understand from this. My next question is for Dr. Anil Kumar. Dr. Anil Kumar, welcome. Would you view non-directed altruistic donors as a safer option or a safer category than directed donations by non-biologically related or unrelated, but non-biologically related donors? What is your view on that? Also, what does THOTA say about this category of non-directed altruistic living donors? Your thoughts, please.
Yeah, thank you, Jaya. And thanks for giving me this opportunity and inviting to this interesting panel discussion. And actually, the presentation made by Lisa was an excellent presentation, and a lot of learning from that and how they have implemented in UK. Definitely, NHS, as it is government-funded system, it is different, as we have like transplants happening. Mostly, majority of the transplants in India are happening in private sector, which are funded but either by the insurance companies or out-of-pocket expenditure. So that difference remains. But still, it is very good to see that both the donors, Fathers Chiramil, which we know very well, and he donated in 2009, and still he is very healthy and very positive about it, and very happy about it. And Mr. Bob also, like both of them have very positive feelings after doing this altruistic donation. So definitely that encourages others also to get involved in, and also the policymakers to pursue this in India. But there are certain issues which remain, which we need to take care. And I think in the presentation which Lisa shared, they have taken care of many of those issues. But definitely a government-funded system like NHS helps in that way. Again, the main question remains whether it is truly altruistic, and we have to rule out the coercion. It is a truly altruistic, non-directed, so that challenge remains. Though we have a administrative mechanism of a authorization committee, which should be able to take care of that. Then another issue is informed consent. We have to inform such donors who are like because of certain religious reason or because of some reasons, they want to philanthropic reason, they want to donate or help somebody, they have a empathetic attitude. But they have to be properly informed of the nature and consequences of such undergoing such a surgery. And then the health status after the donation of the donor, particularly, I think if it can be protection of the donor, such donors through health insurance or through their health status and their quality of life. Though both the donors who are participating today, the quality of life and the health status, it is very encouraging to see, and that motivates others also. But we have to take into account the health status as well as the quality of life of such altruistic donors. As far as legal position is concerned, we have a provision where we say those who are not related either biologically or by blood, such a donor can donate to a recipient by reason of affection and attachment towards such a recipient or for any other special reason. So even if so under this any other special reason, perhaps such cases can be considered where the person is donating out of their because of their philanthropic attitude to help others or their empathetic attitude. So, and we have a mechanism in place of authorization committee, so it can definitely be taken forward. But again, those we have to move it very slowly, and we have to like case by case, as Dr. Nagral has said. We have like each individual case has to be analyzed in detail because we don't want any kind of a organ commerce to happen. That is our primary concern, and that is the primary concern of the law also, that we have to control the commercial dealing. So the law, first priority of the law is to prevent and control any kind of commercial dealing in organ donation. So yeah, thank you so much. Yeah,
thank you, Dr.
These are my comments.
Anil Kumar. Thank you so much. Absolutely well said. Dr. Dale, are you there? I'm going to request you to. Are you still there, or have you left?
I'm still here, Jaya. Thank you very much.
I'm so happy. Okay.
Thank you.
Dr. Garner, I'm going to bring you in next. Can you please share your views, and also can you share as to why this discussion is so important from the viewpoint of learnings and sharing of experiences in this space with other Commonwealth countries?
I think it's a great opportunity. I want to thank all the speakers and for Mohan Foundation for supporting this this event. I think we can all learn a lot from each other. I'm going to answer the question from a deceased donation perspective. What I have observed is our success in increasing the awareness of donation will drive altruistic people to want to donate. Our experience, I know India doesn't do donation after circulatory death, but our experience was that was driven as much from the transplant side as donation side, where families were saying to us, what do you mean they aren't dead enough? They aren't brain dead. They are going to die. We want to make that altruistic gift. They wanted to make that altruistic gift. And our donation after circulatory death program rose because of that. In countries like Netherlands, Belgium, and Canada, which allow euthanasia or medical assistance in dying, very quickly after that was begun, people wanted to make the altruistic gift to donate because it was just a logical thing for them. They want to help people after death. Similarly, I think what we're seeing is once you begin a living donation and have a promotion of deceased donation, altruistic people will want to make a non-directed help the people, not just help a person. They want to make general gift. And I think that's really powerful. So we are, in many ways, this conversation arising is because of the success you've had in India in donation, in both deceased, increasing deceased and living. And my second point is that Lisa and I will vouch that once deceased donation and living donation were quite separately considered, but now we have a united strategy in the UK for deceased and living donation. We are starting to learn how to do promotion that actually promotes living donation as well as deceased donation. And we're coming together. And I think there's an enormous amount the deceased donation community can learn from the living donation and vice versa. And also from a patient public point of view, they don't see the difference. People want to, altruism is altruism. Respect for autonomy is respect for autonomy. And we're seeing that more and more where it's not the doctors and nurses driving donation and transplantation, it's the patients and the families who want it. And we actually are often catching up because they're further ahead than us. I'm very sorry, I'm going to have to go because I'm clinical at my hospital, but it's been a great discussion. I'm really grateful that we can share it across the Commonwealth. Another great initiative. So thank you, everyone.
Thank you, Dr. Dale. Okay, my next question is for Dr. Archana Kumari. Hi, Dr. Archana. We have, hello, Dr. Archana Kumari, are you there?
Yeah, I'm here. Can you?
Okay. Yes, we can hear you. But there's an echo, so that I'm able to hear. So,
is it still echoing?
It doesn't matter. I'll just quickly ask the question and then you can answer. So, Dr. Archana, could you please share your thoughts on non-directed altruistic living donation? And would you think of including this in, I think we all agree that it's an important category. And now that India has made so much progress with deceased organ donation and living donation in any which ways, with, of course, the safeguards and the processes in place, what are your views on inclusion of this category into the Indian systems? And do you think legislative changes should be done, or do you think that it should be looked at on a case-to-case basis? Over to you, Dr. Archana.
Thank you, Jaya. Thank you for inviting, and good evening to all the panelists. I think I'm clear, but there's some network issue in my area, so might be I'm not able to play the video.
We are able to hear you, Dr. Archana. Please go on.
As far as the altruistic donation is concerned, it was really great to hear from Bob and Father Chiramal. It's definitely a different feeling when you are able to give and make a change and susceptible change in someone's life. So it's really good thing. But as far as if we talk about in context of India, definitely our health system, our population and our community is different from UK. So as Dr. Anil sir have also said, and Dr. Sanjay Nangral has said, that we need to make case by case decision. We need to be slow because we have to think about the recipient. At the same time, we have to think about the donor also. In altruistic case, who will take care of the donor? Because his follow-up is also important. And then there is a big gap of economic and other things. So this is one concern. So I believe that if we are moving in that direction, we need to move slowly. And yes, definitely case by case. Otherwise, the organ commerce may rise up, for which all the policy and the law came into picture. Apart from that, my personal view is that if we can, because I believe even disease donation is altruistic donation, there people donate out of love only. So if we work more in strengthening that, that will definitely help with the country and the population India is concerned. But yes, altruistic donation is good if it is more based on the out of love and other things, and no commerce is involved.
Okay, all right. Thank you. Thank you so much, Dr. Archana. Thank you for your views. And is Kamal here? Then I would ask my last question to Kamal, and then we can throw the session open to discussions. Kamal, I don't see Kamal Shah here. All right. So we will then throw the panel open for discussion. If there, I'm happy to address take up the queries that some of the queries that have been posted in the chat box. Just a minute. That was an interesting.
Looking at the chat box, I would just want to ask Lisa, what kind of psychological template do you have, Lisa, in your processes when you assess this donors who come forward? Lisa, you're muted. Lisa, you're muted. You need to unmute.
I presume Lisa's having difficulty oh, there you go.
She's got it.
Yes, thank you. I couldn't unmute because I couldn't do it myself for some reason. Sunil, thank you for the question and really interesting panel discussion. Can I just say, before I answer that specific question, just remember that we have a template for living donation per se, and these people need to adhere to a template, a standard of care that you would give for any living donor, because they're the same people, they're doing the same thing. The point you make is a very legitimate one, and we've had a debate within the UK about this, and we started in a very different way from how we do now. In the beginning, it was mandated by law that we had a mental health assessment for all non-directed altruistic donors for exactly the concern that everybody's raised here, the lack of proximity to the recipient, the worry about coercion and reward, which of course is scrutinised by the HTA in our country, the Human Tissue Authority, for every living donor. So again, your natural processes, your processes and your standards in place will still apply. If you like, it's like having your house that you've built, and then this is the attic on the top. This is the roof conversion. So in terms of the assessment, the mental health assessment, what we have agreed is that every non-directed altruistic donor, because of lack of proximity to the recipient, does go through a formal mental health assessment, and there is a template for that. And we've published that in our latest version of the guidelines, and that is about to be updated. So our latest version was published in 2018, and next year we'll go through another iteration. I think that of care, so we have a template for that. That mental health assessment is carried out by a clinical psychologist or a psychiatrist. And I think there is debate about that, because actually we've talked about the natural proximity between recipients and donors who love one another or have an emotional attachment. But actually, and Bob may be able to speak to this, or indeed your father, there is actually a liberation about not having an emotional attachment. And I've sat for the last 10 years just assessing non-directed donors like Bob. And one of the things they say very often to me is actually not knowing or not having that emotional obligation is a real freedom. And it allows me to do what I want to do because I've got an opportunity to do it, and it's something driven by me. So I just want to put that into, and we had the same anxieties about, coercion, reward, monetary aspects. Actually, they're far less prevalent in that cohort of donors than they are often in in our closer family relationship. So it's just to put that in context for you, really. So it's a long answer to your question, but I hope that's
no. I think that's very important for us, because if we want to start on this path of in India, we really need to go slow, but at the same time, we need to have these processes in place so that things don't go wrong. And obviously, it has to be case to case. Just I know that there may be other questions, but I just wanted to know one more point, which I would like to. One more question which I have is there a rejection rate of these donors come forward? Do you have, let's say, some rejection also where the committee doesn't allow these donations to go forward?
Certainly. So the process is people self-refer into our program, generally as a result of an awareness initiative or something like that. So they self-refer to individual transplant centres. They're triaged at a centre level, usually by specialist nurses who act in the role of living donor coordinators in the UK. That's how we run it. You will find that there's probably around 40% of people who, having had that detailed discussion, decide they won't proceed because they don't want to proceed or it's not suitable. And then they go through a focused medical and surgical review. By the time we've got to close to the end of that pathway, the attrition rate is very, very low indeed. But yes, there are some times when these cases are referred to the Human Tissue Authority, that the Human Tissue Authority do not approve them. But actually, I have to say it's often rarer than some of the other cases which are more complicated, because often family relationships and family dynamics are equally complex as this situation, but it's actually a very low number. The biggest attrition rate is right at the beginning when people make that decision for themselves, whether or not actually when they look into it, they want to do it.
Interesting, yeah. So that if you have 10 people starting off, you say 5 would go through, after the initial assessment, and 40%, you said 40% rejection would be, dropping out.
It's about yes, in our experience, it's equivalent to the related program, if you like. So a similar proportion, and that it will vary by ethnicity, but generally in this population, it's around 50% or more who will actually go through.
I have so many questions for you, Lisa. Maybe I can peep in another one. Is there a gender disparity in this?
Is there a gender disparity? Actually, no, not really. There is an age difference. So generally, very typically, our non-directed donors were aged 50 and above. Our oldest, and he's very proud of this, was 85,
wow.
and I followed him around on the radio when he gave his donation, and he said he was mowing his lawn a week later. So I had to say that maybe that wasn't such a good idea for every 85-year-old to be doing that. But actually, it's interesting. So there's a 50 and above group, and then there's a 20 to 30-year-old group. Now, what we see is that in the 20 to 30-year-old group, in my experience, that a large number may come forward and a larger proportion will probably not decide ultimately not to proceed. But those who do come forward and are really thoughtful about it, do consider that it's something they could do at that time in their life before they get into the complications of family, mortgages, and so on. So, it's that sort of the middle years, as I call them, the middle decades, the 30s, 40s, fewer donors come forward, although since the pandemic, I have actually seen a shift to those younger generations and a shift away from the older generations. And I suspect that's because of anxieties around their own health and so on. But that's the kind of demographic, but not particularly gender specific.
Thank you.
Okay, I have a question for Lisa. Have you come across any of the donors posing conditions around?
Yes.
Yeah. So could you please share a bit on that?
Yes, and we don't do that. So our first premise was when we first started this, and again, I just want to reassure you, although we have now nearly 1,000 of these donors, we started off very slowly and small as well, with small numbers, and so they were the kidneys were offered to our waiting list, our UK-wide waiting list, in exactly the same way as a deceased donor offer would be made, with no conditions about to whom it would go to. And actually, when you explain that to people, generally people understand the premise behind that and why that is. We have had people coming forward saying they only want to give to a child, but after discussion have said they understand that actually if they donate to a parent of a child, they also benefit the whole family. So in fact, and if they really don't want to do that, or there are conditions that they impose that we can't meet, then it's probably not the right thing for them to do. And I think that they may walk away for that reason, which is a perfectly valid reason and perfectly legitimate for them to do that.
Yeah, thank you, Lisa. Pallavi, did you have a query? I saw you had raised your hand up.
I don't know if I missed out that bit, but in the assessment, family consent is taken into consideration. Is that?
No, family consent, not at all. There has been discussion within the community about whether the younger age group donors there should be some sort of involvement from their family, but these donors are all consenting adults, so there's no requirement for consent from the family at all. It is an independent decision, and actually, you know, very many of these people, not all, of course, and Bob's an example of not all, but very many are quite independent. They're living alone. They obviously have, you know, a lot of family and social networks around them, but they are very clear in their thinking, and by the time I would see them in my clinic, for example, they would have really researched very thoroughly, have very clear ideas about what they want to do. They wouldn't come with an ambivalence about it. And in terms of their families, it's really, really important. The discussion I have with them right at the beginning is what do the people who are close to you think about it, and how do your loved ones feel, and have you discussed it with them? And I strongly encourage them to have that discussion early. It can be a deal breaker for some, and often is in the younger generations, that, you know, if mum or dad who have brought them into the world not to give away their own organs object, then sometimes that can be a deal breaker. So I encourage those discussions within the family very early.
I was keen to know what Bob's family, or for that matter, Father Chiramal's and parents or siblings or whoever, what did they have to say about this decision? Because my discussion with my husband didn't go so well.
Well, Bob's family story is very interesting, Bob, isn't it?
Yes, mine didn't go very well with my wife either. We don't have children, so that was one complication perhaps that we didn't have. And no, she wasn't pleased. She wasn't pleased at all, to be honest with you. But she knew that she didn't want to say no, because she's probably afraid I would go ahead with it anyway. And I didn't want to ask her permission because I was afraid she would say no. So we just allowed it to continue. I paid a price for 18 months.
I see you're still together.
We're still together, but it was very expensive, let me tell you, over the next 18 months. But the important thing is I received a letter which had been redacted. It was from the recipient. And I get very emotional about this, but it explained how his life had changed and the life of his family. And that changed my wife's perception. She went from being slightly angry to being very proud of what had.
So Bob, I wanted to ask you, so when I brought this up with my husband, and so he dispensed with the emotional conversation very quickly. He wanted to ask if tomorrow I needed a kidney.
Exactly. Well, and even worse, I forgot my wife only has one kidney.
Oh, Lord.
She was only born with one kidney.
Wow, Bob, you're a brave man.
When she said, and what about I only have one kidney, she could tell on my face I had forgotten that. The point is, there's always that possibility, but we're both healthy. So the risks of actually having kidney disease, and there is a program in the UK that's different in India, I know, but you know, where it's not the end of the line. There is dialysis and there are transplants, and you should survive. So weighing it all up, but I can understand that, and that's a real issue. And I've talked with other donors about the families about what if my children need to, etc., etc. So it's not for everybody. It's for people that can balance those things out. Can I just add one very quick comment? Because the panel discussion was fascinating. And you were talking about speed of pace. You're talking about templates and protocols versus case by case. And correct me if I'm wrong, Lisa, but in the UK, we have both. We have a protocol. It adds consistency and safeguards, but each one is case by case. There is a transplant coordinator. There is a psychological assessment. There is an HTA authorization to proceed. So everyone is case by case within an overall template and format. I don't know if that's helpful or not, but thank you very much. Cheers.
Thank you, Bob.
And I think just to,
yes, Lisa.
I think we'd be happy to share anything at all that would be useful. I recognize we're talking about different health systems, but actually the principles are very similar. And actually, if I can add to that, one of the frustrations really in the UK for our non-directed donors was that we didn't go fast enough for them, that actually we were slowing things down artificially. And in particular, there is still a tendency to do that with our younger donors. And my view of them is that if they come forward, I want them to be thoughtful about it, but the maturity of a 25-year-old can be equal to a 40-year-old in the clinic room. And actually to go by chronological age alone is the wrong thing to do, because it denies people opportunities that they may actually want to consider. And if they come back to me and they say, I've thought about this, I've read the literature, I've discussed it, and I still want to do it, their commitment, I will honour that commitment for them, as will the team.
Absolutely.
I wanted to ask Lisa one more question, if I could. Permitted to, I know I've already asked too many questions, but
that's okay, Dr. Shaw. Yes, please go ahead.
So Jaya, any bad sides, any horror stories, your experience so long?
Yes, there are difficult things, and that I think particularly came at the beginning of the learning curve, where we were learning as a group of professionals, and that is where we'd be very, very happy to spend more time, share our experiences, but as Bob says, we have a way of assessing donors that is already well established, and this is in addition to that. You have a way of assessing donors that's well established. You have a much bigger living donor liver program than we have in the UK, so you know how to do this. This is just an additional aspect to it. So there was somebody that we realised was giving for ideological reasons, and that was perhaps, and hadn't been transparent with us, and we found that difficult, not because of the ideological reasons, but because of the transparency, and so that was a difficult relationship. We have had people who, have perhaps not had their expectations managed as well before as they could have been, and therefore not, because we have anonymity in the UK unless both parties agree to meet afterwards, and had really found it very difficult not to know their recipient or not to hear from them. They're not so much horror stories as complex things and complex dynamics to manage. So things, any program. I use the bifolding door analogy, Sunil, and you've heard me speak about this, but my last slide was the bifolding doors. So the way I look at this program is, if you open your doors to the world will walk through it. And at the edges of that, you'll have the people that walk through the middle, like Bob, who are absolutely, you can totally feel assured that they're doing the right thing for their reasons and they've thought it through. And there are lots of Bobs out there. At the edges of that, you have vulnerable people who are attracted to a program like this. The real key is how you manage that assessment so that you triage the vulnerability. And not let those cases dictate how you manage the whole program. Because if you do that, it will be the tail wagging the dog, because you will miss that fantastic group of people who walk through the middle of the doors, who have all the enthusiasm and the opportunity, Bob's words, not mine, to do this. And it's the people at the edges. So in fact, my clinic, I very often would see people who I knew that we would exclude, but purely because I wanted them to feel listened to, and I wanted to give them a good exit from the program and say, this is probably not for you, and to bring them round to that thinking themselves. So that's what I would say. Don't you will have the occasional case that is a problem and is complex, and those are the ones that you want to focus on, but not to the detriment of the bigger picture.
We have a question from Dr. Satya. Hi, Dr. Satya.
Yes. Hello. Thank you. In fact, it's not a question, it's a comment. Tribute to Life was meant to bring everybody up from wherever they are. And let's not forget that there's a large number of countries within Tribute to Life where living donation is the majority of organ donation being carried out. So if there's a protocol which develops and that is going to be practical protocol, it could be shared with other countries. So this is going to benefit huge number of people. It's a real challenge to make sure that the altruistic donation is really altruistic and really not bound by money or other financial matters. But such a protocol, which can be practical, should be developed, and it should be shared widely with other countries which will find it beneficial. Thank you.
Thank you.
Yes, Satya.
Well said, Dr. Satya.
If I could just comment on the altruism aspect, you'll notice that I dropped the altruistic quite a lot from my discussion, although the legal term is non-directed altruistic donation. That's partly guided by the Give a Kidney charity, actually, because all donors feel that in some way they have a level of altruism. So there's a spectrum of altruism from, donating for purely selfish reasons, because actually, if you donate to your husband, it means you both have a life, and that's not purely selfish. That is, there's a reciprocity there, and there's an obligation for your child, and so on. This is at the extreme end of that spectrum of altruism. But actually, and I think the two donors who spoke to us today would probably say they have gained from this experience. That's, so if you're going to say purely altruistic, actually there is something to be gained, I think, from this, and that is something that is a very positive benefit of it. So I think it is very hard to look for something purely altruistic. I think what we really need to talk about is no coercion, no reward, no commercial dealing, and something that is truly, genuinely given in the gift of donation, in a true gift. And I think that's what we're really looking for, rather than pure altruism, which is actually almost impossible to achieve, because that's very difficult to screen for. But people with a motivation that is totally legitimate is an important way to look at it, I think. But I agree, sharing protocols is no problem at all. I mean, they're published and they're available, so it's a thing to do.
Beautifully said, Lisa. Thank you. Thank you so much. One last call. Is Kamal here? Kamal Shah? Just don't want to leave him out. I called out for him, but he didn't respond. I don't think he's here. All right. So if that's...
I have a quick question.
Yes, Pallavi, please.
Dr. Anil Kumar and to Dr. Archana. So where do we go from here?
Yeah, basically, it's definitely a which can be thought about for implementation in India, no doubt about it. And we have to see, because already we take family into picture, or we take the consent of the family, even in case of where the donation is for the reason of affection and attachment. We always interview the near relative of the donor. So in such cases also we'll have to involve family. It will not be possible to do it without family, at least to initially, without involving the family. So second, just also I wanted to know from Lisa whether organ procurement organizations, the OPOs, those which are mainly doing the disease donation work, do they get involved somewhere in this facilitation of such donations? Because in India we have now NOTO, national level, and then regional level and state level organizations. So basically, who facilitates such donations? Is it the individual hospitals who are getting involved right from the beginning? where these donors approach, or it is some kind of a procurement organization, the common procurement organization? Yeah. So perhaps in India, I think, yeah,
it's the individual.
It's an individual.
It's the individual transplant centres who the donors are encouraged to approach, and they do the assessment. But NHS Blood and Transplant provide a direction of travel, if you like. So we sign people to the right places, and with the help of Give a Kidney, we produced an expression of interest so that they have a central place to go for information, then express interest to an individual transplant centre. NHS Blood and Transplant, as a donation organisation, administer and develop the kidney sharing scheme and take on all the registrations and the kidney offering. So the assessment is done locally in the transplant centres and the centres that refer into them.
Yeah. Okay. So,
Dr. Anil Kumar, just to add to that, what he also said was that these non-directed donations go to the national list, so that the list, sometimes, it can be brought down, the waiting list.
Yes.
So
yes.
eventually, if that is done, then it becomes very neutral who's going to get the kidney, because obviously it comes via your waiting list, and that will be the way forward, even in India, I suspect.
Yes. That is the way it is in India also, because the recipient and the living donor, they are identified by the individual hospitals. Yeah. And if they are now like these donors who are donating without any a recipient pre-identified, so they will be like, they can come to the national list, and then they can be like this paired kidney exchange program. Perhaps that is the best way to go, as has been the experience in UK. So we have to first implement that. Also, we don't have the guidelines for the kidney exchange program yet issued by the government. So those guidelines are also required. And perhaps in that also we can incorporate this element of...
While the guideline may not be there for the paired exchange, but the law permits you to do paired exchange.
Law permits.
And that's why, you are having paired exchange in the country at the moment. The only thing which is required is, can then non-relative do a paired donation, in which this non-altruistic can come in as well.
Yes. Yeah,
and that is a key policy, a key thing in our legal framework, because those two things were introduced at the same time. In all honesty, when this was introduced, we didn't imagine that it would reach the proportions that it is now. This has been spontaneously driven by people like Bob.
Yes.
Really phenomenal progress, I must say. It's something to be learned by other countries.
Yes.
But we're still not as good as we could be, and we're doing more to be better.
Yeah.
So good.
Yeah.
All right. So are there any more questions?
Wonderful webinar, and thank you, Jaya, and thank you, Lisa, for such an excellent overview and having answered so many of our questions. There are going to be more questions, and I think we probably will need another one. But my request to you also would be to record your presentation, if you could, so that we could use it as we go forward, because there's so much information in your presentation.
That's fine. And what I could do is, if it would be helpful, I could add into it something about the assessment process or something like that. Maybe we could have maybe we could have a discussion about that. What would be most useful for you? Because what I gave you was quite, was how we've integrated the program into the UK system. But actually, it may be that there are things that are very specific to your needs, and I'm very happy to do a shorter presentation about that, so people can just use it as an aid memoir or something like that. But whatever would be helpful, just email me directly if you wish. I mean, we're happy to support. That's the great thing about the Tribute to Life project.
And Bob could do talking to all the spouses.
That
could be his unique defined role.
Bob, thanks again for being my wingman, as you always are.
Thank you so much.
All right. Thank you all for your valuable time. It has been such an amazing session. Excellent points have been brought out. A lot of work for us to do over here in India, but excellent discussion. Well, having a strong system is the key to improving the public trust and encouraging more such, non-directed altruistic living donors. Thank you so much, Lisa. Thank you, Bob. Thank you, Father Chirumal. Hats off to you both. Thank you, all the panelists, Dr. Anil Kumar, Dr. Dale, Dr. Archana, Dr. Nagral, Dr. Shroff, and Kamal didn't join in today, but we missed you, Kamal. Last but not the least, I would like to thank our supporters, SBI Foundation and SBI Card. And thank you, audience, for your active participation. Have a great weekend and stay safe.
Thank you.